As a patient who's been diagnosed with cystic fibrosis since infancy, a lot of what makes up what most people can do, such as running, singing, and even dancing, are made much more difficult due to my condition. With cystic fibrosis, my lung function is very inhibited by the mucus that cystic fibrosis causes in those it affects. This results in symptoms such as damaged airways, hemoptysis, wheezing, exercise intolerance, and lung infections. Additionally, I suffer from consistent stuffy nose and sinusitis, making up what makes up most of a healthy person's life much more difficult in someone who is afflicted by cystic fibrosis. Cystic fibrosis also affects my digestive system, blocking the movement of digestive enzymes that allow a typical body to absorb nutrients effectively. As a result, much of my growth and weight gain is stunted, and I find myself constantly dehydrated with a lack of electrolytes in my body. Additionally, because of my cystic fibrosis, I am disproportionately put at a higher risk for conditions such as diabetes, distal intestinal obstruction syndrome, and liver diseases. Other complications cystic fibrosis can cause are reduced fertility in both men and women, osteoporosis, and mental health complications. Thankfully, my cystic fibrosis can be managed with airway clearance techniques such as vest therapy and other treatments that help alleviate the symptoms. But it seems there isn't too much of a fix preventing my symptoms in the first place. I think I'll go ahead and schedule a doctor's appointment to see what other options I have.
Cystic fibrosis, or CF, is a chronic progressive autosomal recessive genetic disease caused by dysfunction of the cystic fibrosis transmembrane conductance regulator, or CFTR. In other words, CF is a lifelong disease that worsens with time and requires one CFTR mutation from both parents to cause disease. Unfortunately, you inherited mutations affecting CFTR on both your maternal and paternal chromosome 7 because both of your parents are carriers. CFTR maintains homeostasis in the body by passively transporting chloride ions across membranes, primarily regulating water localization through ion dipole intermolecular forces. There are hundreds of unique CFTR mutations which you have categorized into 6 classes, which all require different targeted treatments. Your lab suggests that you have 2 of the same mutation, a phenylalanine deletion and amino acid 508 on CFTR. Your cells transcribe and translate CFTR properly. However, this mutation causes misfolding and prevents transport proteins from trafficking CFTR to the cell surface. Functionally, it's as if you have no CFTR at all. Regardless of the class of mutation, all CF patients experience dysfunction in the organs of their nervous, respiratory, hepatobiliary, digestive, excretory, and integumentary systems due to improper chloride regulation. In most organs, thick, dry mucosa clog vessels like the airways in your lungs. We're most concerned about your lungs because they encounter particulates in the air, especially pathogens which can mount infections. Normally, your mucosa is moist and mobile so it can catch bacteria, viruses, and fungi. However, you have mucus which doesn't retain water, so it can't catch and carry pathogens out of your lungs. Consequently, we focus on treatment which help you remove this poor mucus, which I'm sorry is very uncomfortable. This includes percussive therapy by a vest, which inflates to squeeze you and knock mucus off the lining of your airways. We also administer nebulized corticosteroids, like those that asthma patients use to open your airways. Class 2 phenylalanine 508 deletion is now the most treatable form of CF, and it composes nearly 90% of CF in patients. This is because of a 2023 FDA-approved drug combo known as elixacaftor, tezacaftor, and ivacaftor, or ETI, which attenuate the issues caused by your specific mutation. These drugs are known as CFTR modulators, belonging to the small molecule drug class, which are organic molecules which can pass through cell membranes. The E and I are known as potentiator drugs, which promote stability, while the T is known as a corrector drug, which is responsible for promoting proper tertiary structure. Because ETI will restore function to your CFTR proteins, we hope this will allow you to live a normal life that is long and fulfilling. Moreover, you may not have to continue your current treatments, which will save you a lot of time and discomfort. I'd still recommend you using your current treatments in conjunction with ETI, but we can still talk about that as we monitor your condition. I coordinated with my colleague in pharmacy, Dr. Demetrius, to discuss how exactly ETI works and its dosages.
Hello, I'm here to inform you about the fancy new drug you're about to take, ETI. ETI is comprised of 3 drugs that all work together, elixacaftor, tezacaftor, and ivacaftor, each drug having their own purpose, and together they sort of form a superdrug. Firstly, as mentioned by your physician, the CFTR protein is mutated in you. This type of mutation is a deletion of the amino acid phenylalanine, causing the protein to misfold and ultimately compromising its ability to navigate to the membrane surface. Luckily, ETI is the perfect drug for this. Elixacaftor and tezacaftor bind onto the mutated CFTR to guide them to the surface. The increase of these proteins on the surface makes it so that the chloride ions can return to normal, which in turn allows thick mucus to thin out, as well as clearing up clogged airways. The third drug in this trifecta is ivacaftor. This drug aids the protein's ability to open the chloride channels to balance the salt contents. The effectiveness of ivacaftor depends on the amount of CFTR proteins that are on the membrane surface, meaning from the effects of elixacaftor and tezacaftor bringing more proteins to the membrane, ivacaftor becomes more effective in allowing chloride ions to flow through, making it so all three drugs work together to attack multiple types of CF.
Wow, it's super interesting that you guys were able to take the E, T, and I and combine them all together into one drug to help treat my symptoms. What else can you tell me about ETI?
ETI is consumed orally, containing one morning dose and an evening dose. The morning dose contains all three drugs, while the evening dose only contains ivacaftor. Since there are three drugs, there are three different half-lives of each drug at 27.4 hours, 25.1 hours, and 15 hours respectively, which is why ivacaftor is consumed twice. Each drug is primarily metabolized by CYP3A4/5, an enzyme, part of the cytochrome P450 family, produced by the liver and intestines. The primary excretion of each drug is through feces and urine. The bioavailability of tezacaftor and ivacaftor are still unknown, but elexacaftor's bioavailability is 80%. However, we do know how to increase the absorption through the gut. You need to take ETI with a high-fat meal, which would increase its effectiveness by 1.9 to 4-fold. I see you do not have any hepatic impairments and aren't taking any CYP3A inhibitors, so there will not be any drug-to-drug interactions. However, do not eat grapefruits while you take this drug because it is a P450 inhibitor, as well as turmeric and some herbal teas.
Great, I think I can go ahead and plan to eat avocados and eggs for breakfast and maybe even salmon for dinner. Is there anything else I should know?
Other than that, you are good to go. I hope ETI works out for you, and if you have any other questions, please feel free to ask me.
Alright, I don't have any other questions. Thank you so much. Since ETI is such a new drug, I'm wondering if I can get a second opinion on it. I know my mom's a chemist, so maybe I should go ahead and ask her if there's anything else I should know about ETI before I start taking it.
Hi, Edrin. I hope you've been feeling better. I wanted to tell you about some diagnostic methods I've been researching that you can use to monitor your cystic fibrosis. I know you already mentioned high-frequency chest wall oscillation, or the VEST method, in which a vest connected to a high-frequency emitting machine is worn by the patient to loosen thin layers of mucus. You're also most likely already familiar with the sweat chloride test, which is known to be the golden standard for testing CF and measuring the salt levels in your sweat. But maybe you're not that familiar with diagnostics such as bronchoscopy, pancreatic functioning test, or pulmonary functioning test, which monitor lung airway clearance, pancreas functionality, and pulmonary functionality, respectively. Another way you can monitor your CF is by regularly getting blood tested so that your CFTR gene can be analyzed and your levels of immunoreactive trypsinogen, which is secreted by the pancreas, can be checked. Something else to be wary of is CFRD, which is cystic fibrosis-related diabetes. An oral glucose tolerance test is an examination to screen for CF-related diabetes. CFRD is common among people that have CF since the pancreas has difficulty producing enough insulin. Now, here are some stats that may make you feel more comfortable with taking ETI. Ivacaftor in ETI has been shown to improve forced expiratory volume per second, or how much air a person can exhale in 1 second, by 0.39%. The combination of tezacaftor and ivacaftor has been shown to improve lung function and decrease sweat chloride concentrations in patients who are homozygous with the F508del allele. Also, tezacaftor and ivacaftor resulted in improvements that were generally maintained for up to almost 96 weeks, and ETI is the first CFTR modulator shown to stop the decline of lung function. And by the way, in addition to improving lung function and easing your respiratory symptoms, ETI has been shown to improve nutritional status. Overall, sounds like ETI is a beneficial and efficient medicine to help your cystic fibrosis.